Hello, everyone. My name is Christa Natoli. I am CTeL's Executive Director. CTeL stands for the Center for Telehealth and eHealth Law, and we welcome you today to our podcast, the Telehealth Policy Scoop. And we are so delighted to have with us today Dr. Waqas Ahmed with the American Telephysicians. He is going to talk a little bit about the doctor's office in your pocket. But before we get there, I want Dr. Ahmed to introduce himself. He has a great background in a really neat company. So Dr. Ahmed.
Thank you, Christa, and good afternoon, everyone who is watching or will be watching this podcast. My name is Dr. Waqas Ahmed. I'm a nephrologist, kidney specialist by clinical profession, and I'm the founder and CEO of American Telephysicians. We are a physicians-led telemedicine company based out of Jacksonville, Florida, with operations both in the US and international markets. Of course, telehealth is my passion because of my previous my kind of affiliation, not only with my journey as a part of the group, but also I started this journey because I saw the utilization of telehealth in taking care of my parents. And I'm excited to look forward to discuss more how we have grown from just one project to an international company, and also with the support of CTeL, also bringing this benefits of telehealth and improving access throughout the US as well.
Thank you so much, Dr. Ahmed. And you do remind me of our first meeting. We bonded over both being caretakers, you for your mother and me for my grandmother, and how digital health could actually improve access to care to these homebound patients. So you and I have talked a lot about the benefit of essentially having the doctor's office travel with the patient, essentially be the doctor's office in your pocket. Walk me through what was the vision behind this. So you and I have long talked about how access to poor care is not really access to any medical care. And so you want to make sure that is equivalent to the type of medicine that you would receive in person. How were you thinking about making sure that that was consistent with in a virtual environment?
So, no, thanks, Christoph. First of all, I do remember our first meeting, and you're absolutely right. It's just kind of, I'm so glad because the journey for both of us started with a personal experience as a caregiver. For me, it was the experience. My mother, unfortunately, passed away during after COVID because she had a chronic liver disease. And at that time, one of my big challenge before COVID was being away from her, but being the physician's son, how could be involved in her care round the clock or every day. And this is what I thought a utilization of telehealth. Now, knowing being a physician, being also have experienced the care journey as a patient myself, where I saw a lot of issues with the price transparency, and also as a caregiver. I think those three combination kind of made me kind of think, it's not just a technology. When we say telemedicine or telehealth, people usually just, make it that, oh, it's just an online doctor and seeing a doctor, online. And like when we're doing Zoom, it's just like online consultation. In reality, it's way, way deeper than that because I'll give you example. When you go to doctor's office, you just don't just show up and to see a doctor there. There's a process. You just check in, they do the insurance authorization. Then your medical assistant checks you in. She takes all this, patient has to do the paperwork, and then you have to, share your medical history. You also are sharing your other information, which you may have seen other doctors and so on. And then before your doctor sees in the clinic, the doctor reviews your chart and then talks to you, examines you, and then they write, any lab testing, any imaging, and then they tell you if they need any treatment or medication, then they send you a prescription. That's just in the clinic. And but you can imagine there's so many steps. And then, but the journey starts there. And then you take as a patient, you take that diagnostic slip and you go to the labs, unless it's being offered in the clinic. And then you go to schedule appointment for other testing. You may need MRI, CAT scan, or your doctor may send you another doctor's office and you repeat the process and so on. And then you get the blood work done and the results are back. Now you're waiting for follow-up appointments. It is a constant steps. So think for a while. It does take a lot of steps on both sides, a big process, especially if you are living in an area where you don't have easy access to physician, or the wait time is longer.
Yeah.
Treatment gets delayed or so. This where the telehealth is essentially digitizing the entire ecosystem, because that video part is a very small part, but the whole idea of what Vision started is how can we make the whole process digital as much possible. And this requires essentially, and I always give example that this is where every other industry has gone. And obviously, we see banking is online, the virtual campuses for the universities. So, and the vision for us was how can we create a virtual online campus with digitizing entire. And of course, I think we have deployed and we have done multiple projects to do so. And then the journey still continues.
Well, thank you for that explanation. So it sounds like, for our viewers that probably don't know you as well as I know you, it really started as a passion project, how to become a better caretaker for your mother when you weren't physically in her presence. And then that led to creating American Telephysicians, and then actually a sub project, which is smart clinics. And I want to talk to you a little bit about smart clinics, which is the platform that is essentially going to be the digital front door for patients. We a lot of times see that there are digital health platforms that are urgent care specific, but there are, you focus on chronic conditions, specifically in the area of kidney disease. How is smart clinics helping patients with chronic conditions? Like, for example, like with dialysis. Dialysis takes up a lot of time. It's physically draining for the patient. What could be done in a virtual environment that aids that patient in that process?
So, no, thank you so much. You're absolutely right. So, when we launched this company, American Telephysician, the vision was how to build virtual hospital and virtual specialty ecosystems, and again, I emphasize ecosystem because without this, you cannot deliver the quality care. You need to have integration with all the other healthcare service provider, whether it's labs, diagnostic, pharmacy, and so on. And so with that vision in mind, we as a company had built two service lines. One was the specialist physician service line. Our area of focus is multi-specialty. So we work with primary care physician, and then we provide specialty care because that's where the big, lag time is wait time is pretty high and so on. So one is on the clinical service side. The second is we also build our own technology infrastructure to not only deliver our physician services, but we also, building the technology with a vision in mind that we will be giving this technology to other healthcare systems or the payers, the government, so they can also implement this telehealth into their physical infrastructure. So that technology is Smart Clinic platform. So we build that. Is essentially a cloud-based electronic healthcare record system, but it is integratable and integrated with many other EHR and can be integrated with HIS, Epic, Cerner, and so on one side. Second, it also has remote patient monitoring. So because what we are seeing with advancement, data coming from your wearables, blood pressure devices. Imagine you have high blood pressure or diabetes, but You don't need to see a doctor in office because you take the blood pressure at home, your readings goes in the system, and then
Right.
your doctors get. So that's the remote monitoring. And now with the AI, a lot of advanced features like risk assessment, prevention, and so on. So this is what the smart clinic technology we built, and we continue to evolve further, add more features, and have this. Then we took this smart clinic, and since we have a multi-specialty group, we said, okay, if you're providing nephrology service, now let's create a virtual kidney care clinic. First, foundation, hospital, then said departments. So two areas specialty where we have made significant progress, and then other specialty are kind of, catching up also. One is the neurology, which is brain health. So we started at this journey with a stroke, telestroke, and dementia. We established a subsidiary, NeuroX, providing servicing to the telestroke. Again, behind the scene is the smart technology,
Right.
providing service to the hospital for telestroke. And when they get discharged post-stroke in the nurse, senior care at home care. And this is where we also got working with now Medicare. We got accepted in a dementia guide program, which is I think a wonderful initiative by CMS for people or caregiver.
Right.
Second is for nephrology, it's your original question there, which is like, my own specialty. We built an entire solution, teledialysis, which, and we implemented this first in the international market in the Middle East. We have implemented this virtual hospital. The concept is you have a central command center, nephrologists, and other clinical providers are in that command center. And then you have connected that command center with many dialysis units across the country.
Right.
Like we did in Jordan, where we have central command center in partnership with Philips and local partners. And we connected that command center with many dialysis units. And now when you are getting a dialysis treatment, you're getting a real-time monitoring of those dialysis patients. World's first project, because most of the time a dialysis patient are getting treatment, they don't get 24 or continuous supervision. And about 20 to 25% of those patients every week get some complication. You have to stop the dialysis treatment, send them to the hospital, back and forth. And as you know, for Medicare, every dialysis patient gets eligible for, most of them like eligible for Medicare. The kidney care dialysis patient population is number one. It's as per capita, the number one cost, causing them to have a very high cost, because not only dialysis treatment costs, but the frequent hospitalization. And we have made this significant impact in reducing those hospitalizations. So just sharing those examples.
And that's important because this is something that CTeL is going to talk about in an upcoming podcast, but we are in the middle of a clinical workforce shortage, so much so that it probably classifies as a public health emergency. And so if each chronic condition patients are high utilizers of the emergency room, because something happens, they can't see their doctor after hours, and they go in, especially for kidney patients. And so what you're doing here is you are monitoring these patients in real time and then preventing them from having to end up in the emergency room as their safety net. And so that is saving Medicare, Medicaid, and private insurers lots of resources.
Absolutely. And that, just mindful, that's phase one, because that is when they're getting treatment. What we are also offering now doing is when these patients go home after dialysis session. It's very hard on patients, those who get dialysis treatment, they know, or those who are nephrologists, they see how the sufferings are. You're literally drained, your blood pressure fluctuates. Imagine your blood is being taken in the, on the whole every minute, right? When these patients go home, their blood pressure fluctuates a lot. So there are also higher chances that these patients get to the hospital while they're at home during dialysis session. This is where remote patient monitoring is very helpful, because when you're monitoring those patients at home, and let's say if there's a blood pressure fluctuation happening, they get instant connection with the command center, so the nurse and the nurse can communicate with the physician. Any change we can do. Of course, you can't avoid 100% hospitalization. I'm talking about preventable, because you have to have a balance.
Right.
But we're talking about avoidable hospital readmissions or admissions.
And so you bring up a great point. Your program is wildly successful in international markets. It's very successful here too. But a lot of digital health companies find that their success is sometimes initially anchored in markets like the Middle East and Latin America. And some of that has to do with policies that the United States has that makes it difficult for providers to be reimbursed. And so you and I, before we started this podcast, we were talking about, oh my gosh, what is going to happen with telehealth reimbursement? Lydia and I are waiting literally at the edge of our seat to see the continuing resolution language to see if telehealth was given an extension. But this kind of policy uncertainty and chaos really impacts companies that want to invest, and also probably your buyers too, like hospitals and health systems saying, well, we don't know if we're going to be able to be reimbursed for it.
You made a very big point. So I moved to this country about 20 years ago after my medical college, and then I did some training, postgraduate training. I work in different parts of the world. I work in New Zealand, England, in Pakistan. I grew up in the Middle East. And now also, because we have been working with US government for international trade missions, who gave me a pretty good exposure to various healthcare systems, including Latin America, Southeast Asia, and Africa as well. I can tell you that by far the most advanced care is there's no match for the US healthcare system when it comes to acute care. Absolute no match. If you reach hospital, you get the best care and so on. There's no doubt. But at the same time, the highest cost per treatment and a very poor post-acute or preventive care, because that's where the gap is. Everyone wants to kind of, know they can go to ER, and that's like, this. So this is obviously, then this, when you have a deep dive, it's also to do with a lot of policy as well as how the structure is. And of course, we can talk for hours and hours on this one there, cost, the insurance policies, cost by the coverage and so on. You also mentioned the shortage of physician.
Right.
And there is certainly a shortage of physician, but there's also a very big factor into this, because unlike many other countries, where most of the countries, I don't think like this, maybe it can, very few other countries will be like this, where you are required to have a license in each state. Big country, like take example for Australia. So, as say same size as to the EU, pretty big size, but you don't need to have a license for every state. So here, so this also creates a relative shortage of physicians, because now, you're putting those barriers. I'm obviously so glad to see this interstate medical license, IMLC, coming in there. But sometimes you also see some of these states have decided to pull back of IMLC, and some of the states, for example, Alaska is not part of IMLC. You will imagine that want to be part of IMLC and get telehealth there, but because that's where telehealth is needed the most. So you're absolutely right that there needs to be some push by the, on the lawmaking and policy that needs to be, implemented that. Number two, the payment, because obviously I give you example because I think when I was in private practice before I decided to launch this, the reason was obviously one of my mother, but I also used to see patients in my office. I saw those patients who I saw in the hospital when they get discharged. Now I was going to see them in the office. Literally, elderly patient, dementia, sometimes are being brought on the wheelchair, sometimes actually on the stretcher, because if they have dementia, restrained. And I thought like these, and then someone obviously bringing it and there's a cost to bring the two persons, or nursing home is sending two persons on that. and you say that the office visit you do is maybe the reimbursement was like $90 to 110 or $120. That's pretty standard average per visit, right? But the cost to bring the patient from the nursing home to the hospital was literally over $350 because they
Yeah.
have to. So I happened to like, they were curious. I said, why don't we can see those patients in the nursing home? So I called that nursing home and said, hey, I would like to see this. We can see this nursing home. And they said, yeah, sure. You are welcome if you can sort it out. And then I think there was I still remember. So I talked to my senior members of my private practice, and they started laughing at first because obviously I was naive at that time. Like, okay,
Yeah.
they said, how are you going to get a payment for that? And that struck me. I said, okay, because they said the only payment at that time was in the rural areas. So,
Mhm.
and you are sitting in Jacksonville, this is not going to happen. And I
Right.
said, gosh, everyone telehealth, telehealth is not just for rural. Telehealth is essentially, at even what I see, even in the urban areas where even there's a bigger problem for them, especially if you go even bigger cities, you're stuck in traffic for 1.5 hours and then wait time, right? So anyway, I figured this out that that's not going to be a practical thing. And when I started this company, obviously I left my group. I started my nephrology practice purposely in the senior care facility to learn the system, that what are the gaps. There were so many gaps because specialists do not go there. They usually drown because it was so chaotic, fragmented. You have to go chart separately for lab. That was obviously before COVID. Things have improved. And this is where I started this, then implemented the smart clinic and started seeing patient in telemedicine before the COVID. And obviously when the COVID came, with the perfect timing that, okay, we have provided access. Of course, reimbursement did, then we saw a good, adoption because now physicians are getting the payment. They obviously would prefer a hybrid work because then the cost of running a practice with all the high physical campus is higher than the telehealth. And then patient get better access and so on. So when I look at this, I think the Congress or who are the policymaker, they need to better understand the reality is obviously, there are always some bad players. There's some people take advantage of the system and so on there, as you mentioned, they're concerned. But the benefits are way, way higher than the risk or some of the, overutilization. I believe is still underutilized, and the upside benefit and savings are way far to Medicare if they really support telehealth the way it should be.
hmm And you bring up a really great point. If you introduce digital health access to underserved areas like nursing homes that have high medical liability, you are essentially helping reduce liability for that facility. So not only are we helping with the clinical workforce shortage, we're helping with potentially litigious matters into the future, which nursing homes are oftentimes the recipient of because we're dealing with such a massive clinical workforce shortage. So you're right, it does take place in this ecosystem. We have about a minute left of this podcast. And so if you're going to be presenting at CTeL's Digital Tech Showcase on September 23rd. Were kind enough to You were kind enough to join us last March, and we provided a digital showcase to members of Congress, which ultimately led to an extension of those telehealth waivers until September 30th, and we're hoping to do that again. What is your message to those that are listening right now? What could they do to help make products like yours available in terms of policy? What is your ask?
No, I think obviously in order to build an ecosystem, you need an ecosystem approach because that's like policy making, organization like CTeL for advocacy, the participation by all the stakeholders. So I think unless all the stakeholders are on board, and then they also show the support as well as present use cases is not going to be, it would be very hard for Congress, even congressmen or so on, to really understand, because
Right.
they're not like they're I don't know like how many of congressmen have been to nursing home, how many of them have been actually to the sexual play, right?
Little,
So
very little
exactly.
probably.
And even like, I tell you, like, even as a physician, you think like, oh, I was like, before I learned all this, I thought, oh, always saying, oh, the healthcare. You don't, unless you really experience those, when you go deep dive and you start learning. So I think this is where the presentation of those case studies and, experiences so well. And this is where you guys at CTeL doing extremely valuable job. And thank you for the opportunity to not only for this podcast, but also to present this at the Congress, because I think this is, what is really needed to bring all those companies who are trying to bring access, affordability, as well as patient awareness and health equity. Is going to be very valuable, and thanks for making it, a very supportive for us too.
Well, thank you so much, Dr. Ahmed. We appreciate you and your continued support of the digital health community. For those that are listening, it's a open free event on September 23rd at the Rayburn Foyer in the Rayburn House Office Building. You'll have the opportunity to meet with exhibitors that are showcasing the impact that what good digital health has on patients, and you'll be able to meet Dr. Ahmed in person if you join us. And for those that are in a virtual environment, please really think about the impact that telehealth reimbursement is going to have. And if you have government relations offices, or if you have policy teams, work with them to create language or an ask for your members of Congress to ask for an extension. Like that's the big thing here right now. We need an extension, but ultimately we need permanency.
Thank you.
Thank you, Dr. Ahmed.